Welcome back to continue our discussion on Crohn's disease. Joining me once again is Dr. John Fucci. You're with St. John's in Sapulpa, also Associate Professor at the University of Oklahoma School of Community Medicine, and you're a gastroenterologist and hepatologist. Now let's jump in. I want to get back to this genetic component part. It doesn't mean, like you mentioned before we went to break, that you're going to end up with Crohn's disease, but you may be more prone to development of that, or ulcerative colitis and other things. What can we do if we know that there's that kind of history within our family? Are there things that we can do to try to prevent it? For instance, should we try to eat more fruits and vegetables that keep the digestive tract more cleared out? Should we be drinking healthier water? I mean, should we take vitamin C and vitamin supplements? Should we use acidophilus, which is supposed to help our intestines? I mean, are there things we can do to try to minimize our possibilities of acquiring this?
Well, that's a very interesting point. At this point, there are no recommendations in terms of diet as a preventive if you have a genetic predisposition. But you mentioned probiotics like acidophilus. There's a lot of research going on in inflammatory bowel disease, specifically Crohn's disease, looking at intestinal microflora. In other words, the bacteria that normally inhabit our intestinal tract.
Okay.
It's very complicated because most of the bacteria we study in our intestinal tract are just within the lumen. They pass through and they grow there and they eat the undigested food that we can't process.
Mm-hmm.
But there's also bacteria that are actually adhered to the lining of the intestinal tract. And there's a interaction between our body's immune system and these bacteria.
Okay.
And these bacteria can modulate the immune response. And there's some interesting research going on now looking at perhaps changing this flora,
okay,
so that we can get bacteria that may be healthier for our intestinal tracts and may be preventative of Crohn's disease. At this point, we do not have enough information or enough data to make specific recommendations, but I suspect in the next 10 to 20 years we'll know a lot more about this, and we can change perhaps the bacteria. It may be more difficult because the bacteria that adheres to the abdominal, to the gastrointestinal wall, is a little more difficult to study than what's in the middle of the lumen of the bowel wall.
Okay, so taking these kinds of supplements or things like that are not going to be harmful for sure?
No, in general, they've been studied a bit more in irritable bowel syndrome, but they're being studied in Crohn's disease, and they're also being studied in other infections such as Clostridium difficile, in which antibiotics cause the flora in the intestinal tract to be changed, and it predisposes to infections such as Clostridium difficile. And probiotics are being studied in all these things. The data is very early.
Okay.
There's a lot of stuff out there. You'll see all the television commercials. A lot of these claims have not been scientifically proven, although bifidobacter has been shown to help with irritable bowel, and there's some early data about what can help with inflammatory bowel disease. But at this point, we're still waiting. More research needs to be done, but it's one of these things that are hopeful for the future, that we may have some very good treatments working on these probiotics.
Now let me ask this question. If you take away the predisposition by genetics and look at everybody else who you could develop this, even if you don't have that genetic kind of component to it, do we sort of exacerbate or increase our chances by, I'm thinking of the digestive system as you're talking about it, by drinking acid things like soda pop, by eating, maybe high acidic foods, things that we know may be more corrosive because of their acidity too? Or, I mean, do we sort of increase our risk that way, or we don't really
We don't really know. Probably not. There's lots of problems with our diet now. Mostly that has to do with obesity and the other diseases associated with the obesity. Our diets are really bad now. We're seeing increased incidence of diabetes and liver disease associated with obesity, something called NASH, non-alcoholic steatohepatitis, which is almost epidemic now because of obesity. And I'm seeing many more patients than I saw 20 years ago with these phenomena. Wow. But in terms of Crohn's disease, at this point, no. There are dietary changes once you develop the disease, but there's no data right now saying that you can prevent it by changing your diet.
Okay. Okay. So now, then, if that's the case, the person develops Crohn's disease. Now, is there an age range where you tend to see that? Is this Crohn's more of an older adult over the age of 60 or 70, or 30 to 50 or young children? I mean, what's the age consideration?
Well, that's an excellent question. There are two peaks. The first is in young adulthood, and that's the larger peak, and then less chance in middle age, and then there's a peak in the elderly. And particularly for Crohn's involving the colon, there's a peak in 70 and 80-year-old people where they've never had any bowel problems their entire lifetime, and all of a sudden they develop involvement of the colon with Crohn's disease. So the big peak is in young adults, and then it kind of settles down, and then another peak in the elderly.
Okay. Now, you did mention some of the symptoms persons may come up in with. Most commonly, you talked about abdominal pain kind of a thing. When they come into you, what do you do to diagnose that this is really Crohn's disease? Because abdominal pain, you know, is so generic. It could be a lot of different things. How are you going to definitively say Crohn's disease?
Well, the history is very important.
Okay.
We look for changes in bowel habits, bleeding, in particular pain after eating, which we call obstructive pain. In other words, as food passes through the intestinal tract, it can generate pain. Because what happens with Crohn's disease, you develop these strictures of the small bowel when it's infecting the small bowel. What I mean by a stricture, it's a narrowing. So say you have a lumen of the small bowel that's big, the inflammation slowly causes scarring of the lumen of the bowel and gets down to that size. And then food can get caught there, and they can present again with pain, particularly after eating, and distension. So when we have those symptoms, we look for Crohn's disease. We use blood tests to look for inflammatory markers. Certain blood tests suggest that there's an inflammation going on in the biopsy, in the body. The white count may be elevated. They may have an elevated sedimentation rate. They may have an elevated C-reactive protein. These are all markers that we look for as inflammation in the body. But history is the most important. And generally, if someone has unexplained abdominal pain or has had any problems with unexplained intestinal blockages, then we look for Crohn's disease. And we have specific tests to look for Crohn's disease.
Now, let me ask you in relation to this, in terms of, you mentioned about the pain after eating because of the stricture, you know, the narrowing there. How long does that tend to occur? Are you talking about an hour after eating, the next day? I mean, exactly, what's the general time frame?
Generally, it's a few hours after eating because they usually occurs in the part of the small bowel that's at the very end, what we call the distal small bowel, where it hooks into the colon. That's called the terminal ileum, and that's where more Crohn's disease occurs. So if you had a blockage high up, it would occur, your problems would occur with pain and vomiting as soon as you started eating. But in Crohn's disease, it usually occurs hours after eating, sometimes 2, 3, sometimes 6, sometimes 12 hours after eating.
Okay, now with this too, how long in terms of history does a person tend to come, you know, have the problem before they present to you? Is it they've been struggling with this for a month, a week? I mean, is this very severe pain that really brings you in much quicker?
Well, that's a good question. It really depends on the course of the disease. Some people with Crohn's disease have a fulminant disease where they get very sick quickly, and they present very early on. But some people may have mild symptoms and have pain and intermittent problems or diarrhea or bleeding and things like that for years and never think it was all that bad and never go to the doctor, and then eventually it gets worse or they present with a frank obstruction and they come see us. So it's very variable. I've seen patients that have had symptoms for 10 years before they come to see me, and I've seen people develop fulminant Crohn's disease within a few weeks present to the doctor.
Okay, we're going to take another quick break and come back and continue our discussion.
Great.
Okay. Please stay with us. We'll be right back.